So hi, hello, welcome everyone to the NATCO studio room. Today I am honored being with the great personality and a great doctor, Dr. Prakash Shastri from Sir Gangaram Hospital, Delhi, and he is the chairman of Critical Care and Emergency Medicine. Sir, welcome to NATCO studio room.
Thank
and
you.
We are really honored that you are being with us.
A pleasure to be with you. Thank you.
Thank you. So, how does ceftazidime avibactam performed in treating hospital-acquired pneumonia caused by CRE?
You're talking about community-acquired pneumonia?
Yes, sir.
My choice of antibiotic in a community-acquired pneumonia to begin with will not be ceftazidime avibactam. I would like to reserve something as good as ceftazidime avibactam for a relatively complicated case. So, my choice of antibiotics in case of community-acquired pneumonia would be a beta-lactam drug like a ceftriaxone and a macrolide to cover the atypical organisms. Now, I have given these medications for, let us say, 5 days, and because of the patient is staying in the ICU and there are so many other confounding factors, and he is not getting better, he or she is not getting better, then probably by that time my culture reports would have come in, and depending upon the culture reports and their sensitivity profile, then I would think of changing over to ceftazidime avibactam. Having said that, I would use ceftazidime avibactam as a second line drug and not as a first line drug. My experience with ceftazidime avibactam has been decent. Even though the susceptibility profiles may not be very good, because in India the majority of Klebsiella pneumonia, they are NDM1 producing along with OXA48 producing, and on paper at least the combination ceftazidime avibactam is not expected to work. It is known to be very effective in KPC producing Klebsiella pneumonia, not in NDM1 producing, which is prevalent in India, unlike KPC, which is prevalent in United States and Europe. So, on paper we were a bit skeptical about ceftazidime avibactam combination either in bloodstream infection or in pneumonia or VAP for example, but having used it now for good 5 years, our clinical response rates have been very good, and that is why we are not bothering about what the paper says or what it is on paper. As long as the patient is getting better, I would be very happy, and that is what I have seen with ceftazidime avibactam. My clinical experience has been good. I was skeptical because the evidence in favor of ceftazidime avibactam, even with aztreonam, was not very good, at least on paper, when the drug was introduced, let us say 5 years back.
All right, thank you so much for sharing your knowledge. And how does ceftazidime avibactam compare to meropenem in treating MDR infections?
There is no comparison. I mean, there was a time when meropenem was the be all and end all and go to drug, and that was in the beginning of the century, the beginning of this millennium, and it was very effective. And then when it became less effective, then we added colistin to it. That is how it evolved, and nowadays the colistin has been replaced by polymyxin to a great extent. Now in my ICU, especially the hospital acquired species of Enterobacteriaceae especially, they are almost 90 to 100% resistant to meropenem. So the question of comparing these two don't arise. When you know that there is a 90% susceptibility, a 90% resistance to meropenem to most of these drugs, then there is no point in starting it. So there is no comparison. So I would rather not compare apples with oranges now.
Okay, no problem, sir. So what are the clinical offline indications for using ceftazidime avibactam in the ICU?
As I said, now most of my patients where I am getting resistance to meropenem, which is the true situation right now, and we get a Klebsiella in my bloodstream infection, and I really go by my bloodstream infection, because that is one thing which I know it is not a colonizer. I know that it is not going there by contamination, very unlikely. But in sputum, for that matter, ET secretions and urine, there is always this thought in my mind whether I am actually treating a pathogen or am I treating a colonizer. But when it comes to bloodstream infection, yes, obviously we don't have a choice there, and we have to recognize, we have to take into cognizance that the report is there and we have to treat it. In these situations, I have found, now much against my opinion, I was asked to promote this drug by the company which actually introduced it in India way back, and I told them that a drug on which I don't have any conviction upon, I won't be able to convince my audience to use it. This was 5 years ago. That's why I never participated in any of those. I told them that I'll be in the audience, I'll be sitting there, I can come and attend the meeting, but don't ask me to speak on it, because I personally don't have conviction whether this drug works. And as I told you, on paper, if you really go by the theory of it, it's not expected to be effective in Indian Klebsiella pneumonia, secondary infections or VAP or bloodstream infections. But now that I have used it in several cases, and we were facilitated by the fact that we could manage to get a synergy testing done. So I used to keep my conscience quiet by saying that, okay, if the report says that synergy is positive, then I will use it. And then we got that synergy positivity, and now since 4 or 5 years we are doing that, and at least to begin with, I could justify the usage of ceftazidime avibactam because the report was saying synergy was positive. Now, I was pleasantly surprised that whatever the in vitro studies would be, I have now personally used it for now hundreds of patients in my ICU in the last 5 years or so, and my results are quite not amazing, I would say, but they are pretty good.
All right. Thank you so much, Dr. Prakash sir, for sharing your wisdom and knowledge with all of us, and this will definitely help our generation, the younger generation. Not only the younger generation, but also the entire generation. Thank you so much for sharing your.
You should ask me what message should I give to the younger generation.
All right. Could you please share your message to all of us? It will be a great for all of us. Thank you.
See, I started my career in intensive care without a formal training, as they call it. It was a self-training that I did. I managed to know what are the niche areas that I'm supposed to learn. Whether it was in India, I went abroad to acquire those skills and knowledge, obviously. And I thought that I came back as a much better doctor than what I was after my postgraduate training. Somehow or other, our Indian postgraduate training, and for that matter the entire medical education, makes you very good registrars, makes you very good junior doctors. So our professor would be very happy to have them. But somehow or other, the transition from being a good registrar to a good consultant, that some people do it instinctively, but quite a lot of people need a lot of hand holding. And this is the period when their energies go a bit haywire, because they think that they are very good doctors, they have got very good knowledge, and they can treat patients very well. They don't realize that just treating the patient alone is not being a complete doctor. You have to treat the patient's relations. You have to have a good PR relations with so many other members of the family. Basically, you should be a very good team player to become a leader. So those skills have to be acquired over a period of time. And at least when I started, I could not look up to my peers to give me these things. These things have to be developed. I have to admit that going abroad helped me a lot. Not because of the fact that in abroad there are hardly any relations coming to see the patients. Once in a blue moon they will come in, and on telephone they will say, "Doctor, I think you are doing the best thing. You do whatever is best." So, but I think the thing that I learned in foreign country was how to be polite and how to respect the person in front of you as a human being first, and everything else later on. So when it starts looking at a person as a human being, it doesn't matter whether he or she is a relation, he or she is my sister in charge in the ICU, he or she is a junior newcomer nurse in the ICU, or he is a staff 4th grade worker cleaning, so those kind of people. I sort of realized that the basic respect to another person has to be given, and I think that was a huge change when I started working in India, because at least the people would say that at least that person gives you a hearing, and that itself ameliorates lot of their problems. At least they've got someone to tell that this is my problem. So that itself takes away half the pain away. I think that is the thing. And to my registrars, I have to say one thing. I mean, I don't know. They have a lot of concepts about this work-life balance and all that stuff. And I admit that working in an intensive care unit is like doing a penance in Himalayas. So it is hard work. I don't deny that at all. Besides the physically hard work, you are intubating the patient, you are putting lines in the patient, you are transporting the patient for CT scan and other things. In that, they have to focus owning up the patient and treating a patient. So I tell them that just pick up one patient in a week, but start from the beginning, from the day he came to the ICU and to the time that he got discharged or whatever happened in the end. Just follow the patient over a period of time. You don't have to do it for all of them, because for most of my registrars tend to work mechanically because there's so much there. There are 34 patients in my ICU. So obviously they can't keep track of all of them. But I tell them that in a week, you catch hold of just one patient and follow from the beginning to the end, have your own theories, have your own provisional diagnosis, have your own sort of thinking about how I would have managed this patient. And if that is in dichotomy, that is not happening on ground because somebody else thinks something else, then go up to that person and talk to him that this is my thought process. I thought you should have done these things, but you are doing something different. That means obviously my thought process was incorrect. So where did I go wrong? So these are the small things that you need to pick up to become a good doctor, because unless you have the analytical mind working, and brain, is a very lazy thing. Unless you make it work all the time, it works fine with you. But if you don't, you just work mechanically, you can still survive in the ICU and maybe become an average doctor. But if you want to excel, if you want to do well in life, then obviously you have to make sure that your brain is working all the time. You are always asking the question, why this is happening? I wanted to give NORAD to the patient, but that doctor has prescribed adrenaline. You ask him, why did you give that? So these are the small things that, and even if you learn one small thing in a day, that is going a long way forward. So I think rather than being materialistic, rather than being worried about how much money you are earning as a pay, how much of holidays are you having, how early are you leaving from the ICU, whether you are extending your stay by 1 hour every day. I mean, these things are immaterial. The important thing is that suppose this patient comes tomorrow to me and I am the doctor who is the sole person managing the patient, could I do it better than what is being done right now? If they have this kind of attitude, then all the other problems will wash away, because you understand that over a period of time you can take it easy because you will get to learn more. So afterwards, it's initially of course it will be hard work, no doubt about it, but as you go along and as you acquire more knowledge, and I'm telling you very, very simple thing, what your mind doesn't know, your eyes will not see. So the mind has to know. You have to acquire a knowledge. If I need a rickshawala to teach me something, he is my guru, I'll touch his feet. So it doesn't matter where do you get it from. I think that answers your question.
Yes, this is very perfect and really inspired to all of us. By the way, you are actually sharing our lesson to all our new generation and the other generations. I would like to ask one more question to you. During your past doctor's life, what is the best lesson that you have experienced, or what is the best thing that you have experienced in your doctor's life?
I have a passion for teaching. Besides being a good doctor and looking after my patients well, that's true. But I think I have a gift in me which allows me to impart. A lot of people have a lot of knowledge, but not all these knowledgeable people are good teachers. So I think I have that God gift with me which allows me to do that. Despite the fact that I believe in myself and I can do it, but then when you get praise from unexpected quarters, and those praise come so innocuously, they don't even think that they are pampering me or they are praising me. They
Because you
just say
deserve
it
it.
naturally. They say it naturally. It is something like when I was moderating a session and one of my PG students came and told me that you on the stage, you talk the same way as you talk to me. And in that process, she didn't even realize that she was praising me, but that was one of the biggest accolades that I can get. It is something like an actor being told that you didn't act, you were yourself. So that was one of the few things that came. And one more thing, I gave a lecture on antibiotics in a different place than Delhi, and a microbiologist lady came and she didn't know me at all. Her husband is here, and she said that, are you a microbiologist? I said, no, I am not. Then I thought when I came, and because I didn't know you at all, I just came to listen to your lecture because my husband came and he knows you, and I thought that I was hearing a microbiology lecture. And that is again a microbiologist telling me that I am giving a microbiology lecture, that too, and she is impressed by that. So these are the small things that really pep you up, that keep your adrenaline going. You get this. She didn't even think that she was praising me. She just thought that this lecture was to be given by a microbiologist. How is an intensive care person giving it? I mean, these small things, they mean a lot. They don't realize, of course, that the hard work that goes before you actually do it. The younger generation, they only see me walking on the stage and getting all the awards and everything. They don't seem to realize that amount of hard work that needs to go in before you can actually go up there and be as a part of it. I mean, really a lot of hard work is required, and the hard work is basically the quest for excellence. Whatever you do, whatever particular thing that you have chosen, try to excel in it. And unless that attitude is there, it is difficult to really go up, get that achievement. Achievements don't come so easily. You have to put in a lot of hard work, and you should not feel jealous of the people who have achieved it. And you think that why I am not there and why he is there, how much he is different from me. Then you can ask that person that question. Why are you going up to the stage and you are getting the awards? Why can't I? Both of us are almost in the same stature, and we also see the same patients. So these are certain things. So develop a niche. Like I have a niche in which I put in a slot that I am a good teacher. And so many times, those people who were my students once upon a time in the 2010 era, they have become big consultants, and they have told me that we have grown up listening to your lectures, and we still remember those lectures. So these are the things which keep you going, and so these are small things which may not mean a lot to other people, but I think I am talking the way a performer would say, a singer or an actor or somebody would say. When they are on stage, they expect audience to give them an applause. If they don't get it, then that is a problem. If they get it, that's a norm. So that is what we are looking for all the time.
All right.
Thank you.
Yeah. Can I ask one more question, please?
Go ahead.
Is that okay? No. Okay. No problem.
Last question, yes.
So you have already shared your experience as a lecturer, doctor, and as a person. So one more thing, what is the best lesson that you have experienced, or what is the best lesson that you have learned as a doctor or a person? What?
The lessons are not one, the lessons are several. But if you ask me to answer that question, the lesson that I have learned is that a patient might have been treated at a peripheral hospital, in a primary health center, or wherever, and then he has been transferred to you or referred to you. Don't underestimate the ability of that doctor when he was treating that patient.
Okay.
If that particular doctor has not done a particular thing which was apparently obvious, there has to be a reason. It may not be documented, but there has to be a reason. So I would be very careful not to repeat. If he has not done it, I would also not do it. There has to be something either in the history or in clinical findings which I don't have the information right now. Maybe I might get it in due course of time, but I don't have it right now. But something which is so obvious, which should have been done in any hospital, he did not do it. I respect his judgment, and I would really not do it just because it is so obvious, because if I could see it, he could also see it. And if he has not done it, there has to be reason behind. Until I get to know what the reason is, I would also not do it. So this is the lesson that I have learned, to respect the other doctor's lack of action or actions or his approach to the patient. So in the beginning, if I get to know that the patient has written, the patient has a difficult intubation, I will not extubate the patient immediately. Maybe I would prefer to do a tracheostomy rather than extubate the patient, because I respect the judgment of that doctor who has actually intubated the patient. So if he has found it difficult, he might be in a primary health center, I don't care. But if he found it difficult, that means there has to be some element of difficult thing there. and that's why I'll be very careful to remove the tube from the mouth if somebody has experienced difficulty in intubating. I can easily remove the tube if I have put in the tube myself, and because I know what was the degree of difficulty involved. But if somebody else has experienced difficulty, I would respect that and maybe be more very careful in removing the tube. So, this is a small instance that I am giving, an example that I am giving, that is all.
All right. Thank you so much, Dr. Prakash sir, for sharing your wisdom and knowledge
Thank you.
with all of us. And we are so privileged, the NARCO team, entirely privileged that you have to be with us. Thank you again and again.